Hey everyone, my name is Daniel Gataulin. I'm one of the senior research analysts covering biotech here at Chardan. It is my pleasure to introduce Riyad Sharif, the CEO of Oculis, to our virtual ophthalmology summit, where the initial focus is on AMD and diabetes-related ocular diseases. Riyad, welcome.
Thank you. Thank you, Daniel, for your invitation.
Of course. So to get things started, could you please spend a couple of minutes to introduce yourself and provide a brief overview of Oculus, and maybe if you can mention some of the recent milestones for the company.
Yes, of course. So I'm Riyad Sharif. I'm the CEO of the Oculis. Oculis is a biopharma company focusing on ophthalmology with a portfolio of three clinical stage assets, OCS-01, OCS-02, and OCS-05. OCS-01 is the most advanced product, is a topical product, and in fact is the first topical product in phase 3 in retinal diseases, and in our case is diabetic macular edema. And I would be more than happy to go to give more details about the ongoing program, which is called Diamond 1 and 2, which are the two phase 3s. The second asset is OCS-02, is a TNF inhibitor or TNF blocker. Is again also in inflammation, is for anterior segment for the front of the eye, and the focus is in dry eye. And we recently released our phase 2b data. So as well, I will be very happy to speak about them. And the third asset, OCS-05, is a neuroprotective agent class. The therapeutic or the biology is called SJK2 activator. It's the first-in-class SJK2 activator in an indication which is called acute optic neuritis.
Excellent.
The company is based between Switzerland and Boston.
Got it. All right. Excellent. Thank you, Ed. So let's talk about OCS-01. As I mentioned, we're going to be focusing on ocular diseases associated with diabetes. So we'll spend most of the conversation today on your DME indication. So as you mentioned, OCS-01 is it's the lead asset. It's in the two phase 3 trials for DME. You're also looking at other studies for OCS-01 in post-surgery pain and inflammation, as well as cystoid macular edema. Central to OCS-01 is OptiReach technology. Can you tell us about this technology, and can you explain how it enables you to achieve what you are achieving with OCS-01?
Okay. Thank you. So OCS-01, as you say, is based on our proprietary technology, which is called OptiReach. OptiReach is a technology which was developed by Oculis, and it allows an API to basically penetrate the eye in a safe manner and reach the retina. So what the technology does, it allows at least or addresses at least three challenges, hurdles for the retinal penetration via topical product. One is technically we are able to have a very high concentrations, stable, very high concentrations. Second, we create particles which have the ability to have a very long residence time, and we are comparing like multi-hours versus 2-3 minutes for a conventional formulation. And the third, we are able to change physical chemical characteristics of the product, because to penetrate the eye, you need to be hydrophilic in the beginning and then lipophilic after, and we are able to do it. So therefore, the high concentration, long residence time, product able to cross different barriers, allows the product after once into the conjunctiva with the concentration gradient to penetrate around the eye. So it goes via conjunctiva, choroid, retina, and then vitreous. So this allows us really to achieve what we have been able to achieve with OCS-01, which are result or benefit for functional and clinical benefits, which are identical to what we get with injectables.
Got it. Okay, so one injectable or one of the injectables approved for DME is the Ozurdex implant. So in terms of the benefits of OCS-01, you mentioned obviously the ease of administration, right? It can be administered by patients at home on their own schedule or prescribed schedule. Can you talk about potential other benefits of OCS-01 versus Ozurdex? And
Yeah,
maybe also comment in terms of the available steroid dose
yeah,
and
yeah.
the potential dosing
So
regimen.
yeah, so basically, as you know, the two type of products which are approved in diabetic macular edema are anti-VEGF or steroids.
Mhm.
Ozurdex is a steroid, so both work very well. Uh, However, both are invasive. Perhaps steroids slightly more because they are implants today and not injectable like an anti-VEGF. So in fact, they are used after anti-VEGF as a second line. We are coming with a solution which is fundamentally different because while the API is the same, it's a steroid as well, therefore it works, and we have the guarantee that it works actually. In fact, they are approved. The fact that it is topical opens two new markets which are really unaddressed. Uh, um, the first market is a first line therapy, really pre-invasive or pre-injectable as soon as you see the diagnostic. And here I would like to spend a little bit of time because when you see the data in the US, and I am convinced elsewhere is at least similar or perhaps worse, is 60% of patients, 60% of patients in the US today are not treated uh, 12 months after DME diagnostic. And the main reason is we don't have a simple product, non-invasive to treat this patient. So what do? We wait. We wait a disease to be worse. And then once the disease is worse, then the benefit risk ratio between the status of the disease and the risk to inject becomes positive, and then we start to inject them. But tomorrow for this patient, if we have something which has a different benefit risk ratio because it is non-invasive, then we will start immediately after the diagnostic, which is the normal way to treat a disease, is when we see a disease, we treat it instead of waiting a disease to be worse. I mean, imagine you have heart disease and they say to you, and imagine the only drug available is an injection into the heart. What we will do, we will say, let's wait. Once it becomes worse, then injecting the heart will be acceptable. It's really the same. I am just using an example to illustrate the current status. So therefore, there is a huge market which is a first-line therapy before injectable, which OCS-01 can address. This is the first segment without actually challenging the status quo of anti-VEGF and injectable steroid. It's totally fine. The second segment, where we need something else, is actually patients who are not responding well to anti-VEGF. And today, double combination with too invasive is not that used because of higher risks, local risks in terms of infection, in terms of retinal detachment, and so on between anti-VEGF injectable and steroid implant. Tomorrow, with non-invasive steroid, we can combine actually with anti-VEGF and address this patient who are not responding to anti-VEGF. And the good news is in all our trials, phase 2 and the stage 1, phase 2 is actually, we had 4 clinical trials with OCS-01. So this product has been extremely well de-risked. In the 4 clinical trials, we always randomized all comers. We ended up with 2/3 naive patients and 1/3 patients who were treated with anti-VEGF and didn't respond to anti-VEGF. And the good news is, first, product works extremely well. You see results which are identical to what we get with anti-VEGF injectables, which is great. So therefore, we are not reducing the benefit because it is non-invasive. We are getting the same result with a non-invasive solution. This is really important. We are not accepting or tolerating a lower efficacy. The efficacy is the same with the non-invasive route. So this is really crucial. And in the clinical trial, on all comers, results were Excellent. But also when we go to the subgroups, naive or previously treated, the product works in both segments. So it will bring benefit to early intervention or pre-invasive patients. It will allow us to treat a pool of patients which is bigger than the current market. Like OCS-01 really can create a market which is bigger than the current
Hmm.
market by treating early. But also, it will help doctors to treat better and to allow them to deliver better outcomes by also addressing this population which is not responding to anti-VEGF. And why I am raising this population is important. We are not speaking about 5% of patients who are not responding to anti-VEGF. We are speaking about 40% of patients. So almost the half of the patients who are treated today with anti-VEGF are not responding appropriately to anti-VEGF, and they need something else.
Got it. Okay, yeah, that makes sense. And yes, so it looks like there's going to be if successfully taken through through phase 3 trials and through approval, looks like there's going to be a paradigm shift in DME treatments. What are you hearing in terms of patient and physician feedback about the need for new treatment options for DME patients?
Yeah. So the feedback from investigators who are testing this product in the clinical trial is extremely positive. Randomization is going very well. Feedback, and in fact, I was speaking with the investigator just before our call just to ask him to get more insight about how the trial is going. And he said to me, your product is easy to randomize because patients are very happy to have a topical. This is for the
Hmm.
first time ever for a retinal disease where each time they ask us if we have topical and we say we don't have, and we wait to treat them. This is for the first time we have a topical and they're extremely happy. And in fact, this investigator participated in a stage 1 where patients were treated, and then in the end of the trial, patients were switched to the standard of care, which means an injection, and they were not happy. So
Hmm.
therefore, from both fronts, doctors and patients having something which treat efficiently, effectively the disease, being self-administered. You can take it the first day of the diagnostic. You can have it immediately, is of huge value for actually the whole community.
Hmm. Okay, got it. So, and another aspect I wanted to follow up on. So you mentioned as OCS-01 has the potential to expand the DME market, right? A lot of patients are not getting the treatment that they need. So at a steady state, what do you think the addressable market will be for
Yeah.
DME?
So if we speak only about the US, and if you remove undiagnosed, you take only the diagnosed patient, and from the
Hmm.
diagnosed patient, so therefore these patients are known, so they are diagnosed. So for this patient, we have an OCT basically. So we know their name, their address, and we have the picture of their eye. So for this patient who are diagnosed, if you remove the patient who are treated with anti-VEGF, we have a remaining 1.3 million patients in the US who are known, sick, and they are not treated. So we are speaking about huge opportunity, bigger. I mean, again, bigger than the current market.
Hmm. Got it. Okay. Let's shift the gears a little bit and talk about data that you've seen so far for OCS-01 and DME.
Mm-hmm.
So you've
Mm-hmm.
completed a couple of trials already, and while I understand they are not head-to-head against Ozurdex, can you still, do your best to summarize, the performance of OCS-01 versus Ozurdex?
Yeah. So I would be focusing on the two regulatory endpoint, which are BCVA and responders. These are the two or gainers. In terms of efficacy, we have an efficacy of 7.6 letters at week 12, which is similar to or identical to anti-VEGF, monthly injected, and slightly higher than what we get with Ozurdex. And the difference is really expected in terms of better efficacy for one reason. The API is the same, of course. So therefore, it's really nothing to do with the API itself because it is a dexamethasone. It's the same dexamethasone. So therefore, it's not the API which is making the difference. The difference is really driven the benefit or the upside from OCS-01 versus Ozurdex is driven by the fact that we are able to reach a certain concentration, and because we give it every day, we are able to maintain this therapeutic concentration. While Ozurdex is a good product, but Ozurdex is an implant, so therefore it is a reservoir. So therefore, when you think about the PK, and actually Ozurdex team did a very good job showing the PK and so on. When you think about the PK, it goes up and down, and then you have a peak, but then it goes down rapidly. And I think this is where the Ozurdex does not have a lasting effect, or at least as expected lasting effect as in the label. So therefore, OCS-01 is able, while not invasive, to deliver a better result. Even again, as you said, it is not head-to-head, but when you put data in front of each other, you see better result with OCS-01 than with Ozurdex. And again, even if it is not head-to-head, this is on BCVA. On the gainers, again, we have also 10-point difference actually. So it's big between OCS-01 and Ozurdex. So we have more patients gaining 15 letters than Ozurdex. And also it has another benefit, which is we have less patients losing 15 letters, perhaps for the fact that it is not invasive. So therefore, I would say I really do not compare actually OCS-01 to Ozurdex because they are addressing different patient need. Ozurdex is really after anti-VEGF. OCS-01 really brings results first, which are slightly better than Ozurdex or better than Ozurdex, depending how we see them and depending on which item, but better. But more importantly, it addresses markets which are not addressed by any of the current therapies because they are invasive, which are first line or early intervention, really as soon as the patient is sick. And the second segment where patients are either not responding to anti-VEGF or not compliant, because then it becomes a combination to bridge between injections. So therefore, this is, I mean, when you think about it, and this is really what the KOLs tell us, they say to us, listen, you have such a great product because it works, it's safe, and it's versatile. We can adapt. We can go to many patient groups, many patient profile, and adapt your treatment.
Yeah, got it. Makes sense. And then now let's talk about your phase 3 trials. So you're enrolling 2 phase 3 trials for you've completed stage 1 previously for a phase 3 trial. Can you talk about the key differences, from your earlier studies into phase 3? Did you change any key inclusion or exclusion criteria? And maybe specifically, how do these trials in terms of patient population differ from other DME trials?
Okay. So basically the phase 3 Diamond program divided in 2 phase 3s, Diamond 1 and Diamond 2, are very similar to other phase 3s done with Ozurdex or anti-VEGF, very similar. All comers, nothing really different. Perhaps the only difference is with early VEGF, like with Lucentis, for example. When Lucentis phase 3 was done, we didn't have VEGF before. So we had all comers, but they were all naive. While here we have naive and previously treated, but just the history of the cycle. But it's very similar to other phase 3s did in the past. In terms of inclusion, exclusion criteria, it's very similar. It's actually identical to what we did for stage 1. The only difference really between stage 1 and stage 2 is stage 1 was 12 weeks and stage 2 is 52 weeks per FDA guidance, per FDA and the phase 2 meeting. So we are just following actually extremely diligently what we agreed with FDA in the end of phase 2.
Got it. Okay. And how is the enrollment? Can you comment on the enrollment progress? When did you initiate those phase 3 studies, and
So yeah.
any guidance on when you might read out the data?
Mm-hmm. So basically, we started Diamond 1 in December last year. We started Diamond 2 in February this year. We always said we would need more or less 12 months to randomize and 12 months to treat. So therefore, plus, of course, we have always 6 weeks in the end for the database lock and so on. So we didn't give specific guidelines. I always say, give us at least 6 months for each trial to have the true rate, and then we can do forecasts. But what I would say so far, we are very pleased with the randomization rate. Extremely pleased, actually, with the randomization rate.
Excellent. Got it. Okay. So one aspect of the study design, especially the loading phase,
Yes.
it includes 6 weeks and 6 times a day dosing regimen, which may seem like a lot. So I wanted to ask if there are any concerns around patient compliance, to not forget, all the 6 doses, and any comments regarding that dosing regimen for loading from patients or physicians.
Yeah. So the study, as you said, has 2 cycles. One is the induction, and one is maintenance. The induction is 6 weeks, and in the first 6 weeks, and then after is maintenance. We tested this model in the stage 1, and it worked extremely well. In the phase 2, we tested even further because we measured compliance, and compliance was very high, like higher than 90%. So therefore, compliance seems to be very high. And as you know, compliance is driven by symptoms. These patients have symptoms, they are losing vision. Compliance is low when we don't have symptoms like glaucoma, where compliance is around 55%. But when you have symptoms, compliance tend to be high. In fact, if we have a lot of symptoms, we tend to be over-compliant. If we have pain, we take more than what was prescribed, or fever or something. So really, compliance is driven by symptoms. So compliance in this situation is very high. As measured in a phase 2, it was higher than 90%.
Mm-hmm.
And again, in our conversation, and as I shared with you, I was really with an investigator this morning, and I asked about any challenge into the study, and he said, no, you have a very friendly product for patients, and a product where investigator, based on your data, feels very confident, and therefore we are very motivated to do your trial because we like it.
Mm-hmm. Got it. Okay. So one other thing that I wanted to ask, and how it may translate into between stage 1 and stage 2. So they have the same loading or induction regimen. And then for stage 1, it was a 6-week follow-up, I believe. And it will be obviously, longer follow-up for stage 2. How did the results or response change from the induction phase to the 12-week readout for stage 1?
Yeah. So for stage 1, we had really 2 questions. The first question is how much we can drive efficacy with the loading, and then the second till week 6. And then the second question, how much we can maintain it or potentially incrementally improve it. And this thinking is really coming from the experience we have with the current treatment, where we have a loading. In fact, we have induction therapy with when we do PRN with anti-VEGF, we give 3 injections and then we adapt based on the need of the patient. This is really what we did. So the model is the same, and in fact, the DME treatment responds with an induction phase and then a maintenance phase, because you reduce the edema, you regain your vision, and then you maintain it. So therefore, it's really based on the pathophysiology of the disease, but also what we know with the current standard of care. So we try to mirror it, try to adapt to the disease, and we try to learn from the insight we have from the standard of care. And the good news is the responses were yes on both questions. Yes, we are able to drive the efficacy as anti-VEGF, and the second till week 6. And then the second question, are we able to maintain it, or at least maintain it, or incrementally improve it? And the response is yes, we actually improved, which is similar to what we see with anti-VEGF. With anti-VEGF, for example, you see that the gains, the 60% of the gains are really made in the first three months. And we are there. So it gives us very solid confidence that these gains are maintained and will continue incrementally to improve over time till week 52, which we see with anti-VEGF.
Got it. Okay. And to confirm, if over the longer maintenance phase, if patients are kind of falling back, there's no protocol amendment that you can increase dosing to more than 3 per day for maintenance, correct? They'll have to stay on
No,
3
the
per day.
protocol is 3 times per day. Yes.
Got it. Okay. And with respect to safety, I think increased intraocular pressure was one of the more common treatment emergent adverse events. I think it was about 14% or so. How significant is that for OCS-01, and was that the transient observation, or did it stay, throughout the dosing?
Yeah. So basically, for intraocular pressure, so around 10%, 11% exactly in the previous trial, 7% in the one before. So between 7 and 11% of patients took an IOP lowering. They all responded to the IOP lowering, and no one stopped the trial because of IOP. And once they stopped OCS-01, it was 100% reversible. So therefore, it is not a side effect which is not controlled. It is known. It happened in the beginning, and it is treated with IOP lowering. And in fact, we have, for example, when you see a gene therapy, when we need to use steroids for inflammation, we end up to have the same IOP. Actually, it's really the same. It's the same rate of IOP as gene therapy because we use steroid as well for inflammation. So therefore, this is something which is good news is known. It happens in the beginning. So it is not something surprising where you do not see anything and then at month 8 or 9, something happens suddenly. So it really happens in the beginning. We know it well with Ozurdex. And of course, we need to treat them. And there are many treatments, and they all work very well in this type of IOP. But it means that 90% of the patients do not have anything, and they can pursue their drug without any worry, basically.
Got it. Okay. And one last question with respect to safety. So cataracts are also known side effect of ocular steroids. In your studies to date, have you seen any evidence of cataract formation?
Yeah. So we didn't see, in fact, we didn't see any cataract formation in the studies we did, which were 3 months. Let's see in 12 months. Now, as you may know, also cataract is the frequency of cataract is very high in diabetes patients. It's between 2 to 3-fold. So basically, think about it this way. If a patient needs OCS-01 and he's 65, even if we generate more cataract, then it means that he might have cataract at 66, 67 instead of 68. This is what it means, really. It is not like, yes, here and no cataract on the other side. Diabetes patient will have cataract. Diabetes generate more cataract. So therefore, yes, product might accelerate a cataract potentially. Let's see, Ozurdex, yes. But because we have a very low concentration in the vitreous, and cataract following Ozurdex is posterior capsule cataract generated by a high concentration of steroid into the vitreous, which we don't have actually. We don't have at all. I would say let's wait the data. But
Mhm.
even if our data are similar to other drugs, in fact, we are not generating, we are potentially accelerating cataracts, which regardless will happen in this patient.
I see. Got it.
Yeah.
Makes sense. Okay, and I see we are coming up on time, and wanted to end this with one last question to kind of bring it all on together. What do you think investors are still missing about the Oculus story?
I think the coming with a product which is totally innovative, which is not plug and play. We don't have another injectable, which is easy to understand because we are going to take one part of the market. No, we are coming with something which will, it is a paradigm shift. It is going to completely change the way we treat DME patients in the future. And each time you come with such an innovation, it takes time to explain, educate the market, and we are doing it. And I remain extremely optimistic about the future. I mean, investors are following. We have good discussions with them, good questions. And I think step by step, we will reach the point where they will really understand how big the opportunity of O1 is actually in DME and in other retinal diseases. But is innovative, is very innovative in terms of changing totally. It is a transformation in terms of paradigm shift for DME treatment.
Got it. Okay, excellent. On that note, I think we'll end the session. Riyad, thank you again for joining. I really appreciate the
Thank you very
time.
much. Thank you, Daniel. Thank you very much. Have a good conference.